Hey, good morning. Welcome to the first Show Me the Science episode of 2023. I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System. Today, we welcome Chief Medical Officers from across Kansas and the Kansas City Metro to take a critical look at COVID, the past, the present, and the future. Our panel of experts today include the following: Dr. Mark Steele, who's the Executive Chief Clinical Officer at University Health Truman; Dr. Jennifer Scripture, Infectious Disease Physician at LMH and Public Health Officer for Douglas County; Dr. Edward Kammerer, Chief Medical Officer at Mosaic in St. Joseph; Dr. Heather Harris, sorry about that, Heather, Medical Director, Hayes Med; Dr. Lisa Hayes, Chief Medical Officer at Advent Health Shawnee Mission; Dr. Kevin Dishman, Chief Medical Officer at Stormont Vale Health; and Dr. Richard Watson, co-founder of Motion. All these good folks have been on the program together before. I can't wait to have this conversation today. It's going to be fun to hear what everyone's seeing and what Dr. Motion is seeing across, or Dr. Watson is seeing with Motion across Kansas. Now I'm going to call you Dr. Motion. I'm off to a great start this morning. Hawkeye. Hey, welcome back. Medical Director of Infection Prevention Control is in the house. We have a lot of things to talk about today, including some questions for our viewers. Make sure you get those questions sent in to us on YouTube, Facebook, and the Medical News Network. You find links to those right here on your screen. Show Me the Science is an opportunity to talk about research, but today we're going to talk about research, but we're going to put a little bit of a different slant to it. Instead of one research story, we're going to hit multiple different areas of current research around COVID, ranging from variants to vaccination. All that momentarily, but first let's take a look at the impact of the triple pandemic, the triple-demic of respiratory viruses circulating at area hospitals and health systems. We're going to start with the impact here at the University of Kansas Health System. Hawk,
yeah,
the COVID numbers are up.
Yeah.
Influenza and RSV numbers are down. I like that trend. Not happy about COVID.
No, we saw an increased numbers yesterday. We don't know if some of that was just administrative things. We have to remove those flags from active to recovering. However, today we have a little bit less. Unfortunately, not as much less as we would like. Yesterday, I think we had 56 active. Today, we have 51 active, with 76 total patients there. Of those 51 active, we have 9 in the ICU and 3 on the ventilator, and so that is quite concerning for sure.
Yeah, no, we had a total of 81 yesterday when you put in the recovering. So we still have a lot of patients here in the hospital, and really, if you step back and look at it, it's a fairly significant surge relative to where we have been over the last few months. Not like last January, but still really high compared even to the prior January. Little afraid of what could happen with the XBB variant, now the dominant variant, Hawk. Yeah. It's like 49% of COVID in the U.S.
Yeah, I think also the other issue is, number one, we know that there has been lower booster uptake, so we know that will not provide as much protection against hospitalization. We also know Paxlovid really probably isn't being utilized as much as possible, especially for those high-risk people. I think the one thing we should continue to remember, though, is that really everything we are seeing now, instead of new Roman or Greek letters such as Alpha, Delta, we only had offshoots or lineages of Omicron. So really that is what we are dealing with right now. And there's been several good publications showing that Omicron is about as severe as Alpha and the other variants were, except for Delta, which was shown to be have a higher risk of hospitalization. So we are still dealing with essentially the same virus, but it's really about getting those people protected, making sure they're up to date with their boosters, getting them tested early, and getting on Paxlovid early to help reduce that risk of hospitalization.
Yeah, and we know that the numbers of public health data we have for a number of new cases are hard, especially for the holidays, but more than that, there's so many tests at home now. But what we can count on is hospitalizations, and hospitalizations nationwide are up 6%. Yep. We also know that there's concern because there's such a high community rate of transmission that many counties are back into the red zone, which historically the CDC has said put on masks. I don't think nobody's arguing at that point at the moment, but I do think it's gotten increasingly dangerous. Do we have a heat map ready to roll? Yeah. The heat map across the U.S. still showing quite a bit of red. There's some nicer yellow, paler zones out in the Rocky Mountain West. You can look down the southern, now the eastern seaboard, and see a little bit more of it taking off. Still, as I said, the rising number of hospitalizations across the United States, probably the best indicator where we are in the pandemic. You've heard our numbers. I want to roll around our panel today and ask them real quickly, how are things in your hospital? I'm going to start with Dr. Mark Steele, Executive Chief Clinical Officer at University Health Truman.
Yeah, good morning, Steve. And here at University Health, sort of a similar story to what you guys have there at KU. Our numbers are up a little bit, slightly down from yesterday. We currently have a total of 35 patients in our two hospitals. There are 26 that have active infections, 4 that are in the ICU, and 1 who's intubated. The other thing that we've seen is a pretty significant increase in our COVID test positivity rate. Last week, we were around 12%. This week, we're as high as 18%. We also have seen an uptick in our employees' infections. Particularly, we saw a big increase following the Thanksgiving holiday. We've continued to see higher numbers throughout the month of December, and it'll be interesting to see what happens here post the Christmas and New Year's holiday. So we're busy here. We're holding 12 in our emergency department this morning, and so that's kind of the story from our perspective.
Thank you, sir. Yeah, I'm with you, and I think that surge we're going to see after everybody was inside with the Christmas and New Year's Eve, parties and get-togethers. We'll see how that plays out. Dr. Jennifer Scrimshire at LMH and Douglas County. How are things there?
I think pretty similar to everywhere else. We've been right around 10 inpatients. Right now, we don't have any in the ICU or on ventilators, thankfully. We have had a problem, as everyone else, with just not enough beds or not enough available beds, staffed beds. We've been holding in the ED, and I think part of our COVID numbers aren't reflected in the fact that people are being admitted but discharged from the ED with COVID. So we don't keep track of those. Employee numbers are up. We have about 20 people out, mostly COVID, some flu. I think this is under counting, as is the percent positivity and the number of the map. I think that you showed a minute ago, the heat map is misleading. I think it's a lot higher than that. The other thing is we're still seeing deaths. We had 2 deaths in December, and it's a reminder to folks that this COVID is still here. It still kills people. You still need to get vaccinated. And for physicians, there's treatment available that does decrease the risk of mortality. So not anything sunshiny this morning, but the good piece of information is it looks like our flu and COVID, RSV numbers are dropping as well. So I'll take that.
Yeah, that's actually really good. Our numbers are down dramatically, and so that's been great. Okay, so Dr. Edward Kemmerer, Chief Medical Officer of Mosaic and St. Joe. How are things up in I would say the Northland, but you guys are way north.
Yep, we're a little north. Thank you, Steve. So we're currently sitting at 23. We've been smoldering along at kind of 10s prior to in the hospital. Prior to this, now we're with this last little bit of surge, we've been up in the 20s and 30s. And so again, we're kind of experiencing Dr. Jennifer's pattern as well. We've had about 20 deaths since July. If you look at it, it still does. It's kind of 2s and 1s per month. It's not really it's not like a ton of deaths per month, but we continue to smolder along, and that's a disturbing trend that we continue to see those deaths again from the underutilization. Bed capacity is the same issue. We're experiencing that same issue. I think this is the new norm. We're all going to have X amount of people inside of our hospitals now every day with COVID, and it's not seasonal. And so, if we're taking 23 extra beds, everybody always thought we were always over-bedded. We all had extra capacity, but I think that COVID has kind of absorbed that capacity, and it's chronic for us anyway. It is a chronic smolder since Omicron came on the scene a year ago. As far as our positivity rate, go ahead. As far as positivity, we're about 15%.
No, you go ahead. I'm sorry. I thought I apologized. No, you go ahead.
We're about 15% on the positivity as well. So that was all. Thanks.
Yeah, so it's pretty high. And I would just say there was a time when people thought, well, we're way overbedded in our metropolitan area. We don't have all these certificate needs, blah, blah, blah. But at the end of the day, we are no longer overbedded, and we are certainly not overstaffed for the beds we have, because that's the other challenge we have. Dr. Heather Harris, how are things in Hayes?
Yeah, we have a very similar picture out west. Oh, can you hear me?
Yes, ma'am. Go ahead.
Right, great. Yes, very similar picture out west. I would emphasize we're running 5 to 7 COVID patients a day, but almost the same number of flu patients as well. I think people were very unvaccinated from flu. Our sicker patients, even our ICU patient today, is an influenza patient, not a COVID patient. So I'm really stressing the flu vaccine. It came early in a hurry. We usually have another wave of it in the later early spring or later winter. So I've been really pushing to try to so we don't have another wave of that impact of the flu. Again, staffing's an issue, kind of the similar concerns as back east as well. But yeah, still really pushing vaccine. And then, letting those older folks, if they do a home test, which we're certainly encouraging, is to make sure that they let us know quickly at the office so maybe we can get them some medication as well.
Indeed. Dr. Kevin Dishman is the Chief Medical Officer at Stormont Vale Health. How are things in Topeka, sir?
I'd have to echo what my colleagues have said. One of the keys, I think, is something that both Dr. Kammerer and Dr. Scrimshire touched on, and that's the chronicity of this disease that we're seeing develop. And so we have been at 15 to 17 patients, which you've already heard is the experience of other facilities, and we're staying consistently at that level. I am happy to report we don't have anybody in the ICU and nobody on the ventilator at this point. We're seeing the same challenges everyone else is, but I'm brought to a focus on how chronic this disease has become, and we're all starting to use that word, which I think we're hearing both from our colleagues there at academic centers and also across the state and now nationally that the chronicity of this disease is going to be a challenge going forward.
Well, I think that's totally true. If you think that, a few years ago, we didn't have anybody in the hospital like this, and now 10 to 15% of our hospital beds are taken up by one disease entity, one viral entity. And I'm a little concerned how high those numbers are going to be in 4 to 6 weeks because of the high percentage of COVID that we're seeing on our testing and the fact we just went through the holidays. We know that in the last 2 years, that's given us a surge thereafter. I want to talk now with Dr. Richard Watson, who's a co-founder of Motion. We've been having a conversation with Dr. Watson now for a couple of years, and it's always so informative because I think his story and the information he has is like the bellwether of how things are going on. I don't know that we talk about it enough. Dr. Watson, tell us a little bit again about what Motion is and what's the data showing you in Kansas?
Hi, again, thanks for having me on. Motion is software that tracks transports throughout the state, and it follows the movement of the patients from the outlying facilities to the metro centers. And I think over the longevity of this disease, we've seen that the cyclic nature of just a regular virus and what it looks like, but in a very non-immune population. Lately, it's been the same story, but I think it is starting to speak of the flavor of what we're going to deal with over the coming years. Certainly, as we went into November and December, following Thanksgiving, we saw real challenges in relationship to patients moving and increasing times. We've tracked facility capacity update, which is a 1 to 3 scale, that 3 means there's no capacity in the system. And we stayed right at a 1.8, 1.9 up until Thanksgiving, where then we crested 2.4, 2.5, 2.4, 2.5. Going into December, it looked very similar. We were slowly rising, but then as we hit the late December time and early Christmas holidays, we are at 2.8 up until the end of the year. And I think it speaks to this fact of that this disease is one that is going to present anywhere from 5 to 15% of the patient population is going to be admitted at any one time, and that number in and of itself produces complications due to the staffing problems that we have. We can't get past the fact that when we're running 95, 97% census at referral centers, we don't have the ability to move patients out of the rural areas. And so we saw times go from anywhere from 1 to 3 hours to now 3 and 4 hours waiting to get patients moved out of the rural facilities into other hospitals. And it's a very select group of patients, there's no question about that. But any complication, when we talk now about a buffer of 5 to 10% changing the landscape of healthcare in our state, that becomes a real problem for everyone.
Yeah, and I think that's your point about having this for a long time. You get these time-critical diagnoses. We've said this before. This can be a real challenge for all of us. So I think there's a lot to be digest here. But I want to move into our first kind of topic area question. Then what I'll do is talk to the panel, and I'll ask each of you, I won't ask each of you every question, but we'll make sure we get to everybody about one of these different questions. So, it's true that some viruses took a little bit of a break during COVID. And some of those are now back with a vengeance. We're talking about especially influenza type A and RSV, but also even rhinovirus and some of the other coronaviruses, et cetera. We knew that we talked about RSV and flu, and monkeypox came along. So the list is kind of long that had gone a little bit of a hiatus. The viruses that really haven't changed. Now, they've been around for many, many millions of years. Media often asks if this is because our immune systems are weaker since March of 2020. I don't think our immune systems are weaker, folks. We've been having plenty of illnesses out there to deal with. I would think we might have less exposure and perhaps a little less acquired from immunity. Let's talk to folks about that. For this one, I want to turn to our two infectious disease guys here, Dr. Scrimshire, Dr. Hawkinson. First, Hawk.
Yeah.
Is our immune system weaker? Were we really less exposed? I think we were exposed to a lot of COVID and other stuff.
No, I mean, I think our immune system was functioning properly as it should, but to your point, there was certainly less exposure there. There was less exposure to those other more common respiratory viruses, especially as we're going to stay in that realm right now. We know rhinovirus still did circulate, but there certainly was less exposure to other cough and cold viruses, influenza, RSV. We saw those other changes in the time frame of RSV as opposed, for example, when it would normally hit or strike a population, we saw that time frame was delayed. So I think the immune system continues to function as it should. We got plenty of sampling from our environment from different things, but for respiratory viruses in general, certainly there wasn't as much exposure there because of those public health measures that most people were doing at that time.
Dr. Scrimshire, is that what you're thinking as well? I mean, to me, the immune system has to stay primed all the time because there's infection coming from everywhere, not just viruses.
Yeah, I think, 2 points. One, masks work. It's weird, right? We all wore masks and we stopped spread of disease.
Are you saying that masks helped us? Oh my God.
I know.
Shocker.
It is. I'm going out on a limb there, but yeah, we all wore masks. We weren't as crowded as spaces, so there wasn't as much transmission. I think if we were to have seen an increased number of flu deaths or an increased morbidity and mortality from things that usually circulated, I think that would lend to decrease immune system efficacy, but it's just that they weren't around as much. They weren't spreading as much. These bugs have been around long before we were here, long before global travel was a thing, and they're still here. We're just seeing the fact that people are getting together and not wearing masks.
Well, I just say I think there's still transmission from food, from fecal oral to surfaces to all sorts of things that masks did not really protect us against. And so it feels like we don't really have weaker immune systems. And to those who say that, oh my God, influenza is so terrible and RSV is so terrible because we all wore masks, remember, and Dr. Scrimshire, correct me, I think we've had some really bad RSV and influenza years before COVID ever existed.
Oh, absolutely. Yeah. And we see people die. Dr. Stites, Dr. Hawkinson, Dr. Steele, anybody who does clinical practice, you see people die every year from influenza. So it's still serious. We just had a break from it for a while.
Dr. Dishman, I see you shaking your head. I guess that means you might agree that masks work.
Oh, I think certainly, we went back to basics, and I think that's extremely important. Even on the radio last night on the way home, I heard a disc jockey, really asking people, wash your hands. It really goes back to what your grandmother always told you, wash your hands. So we wore masks, we washed our hands, and we saw positive results from that. So really, it's a back to basics approach. It's things that we always knew to be true, that, like I said, our grandmother knew to be true. And I think I agree, certainly with Dr. Scrimshire, that we took actions that were very simple, that were very straightforward, and that made a positive difference. And I think that tells us what we need to be focusing on as we go forward.
Yeah, and there's plenty of different of infectious disease pathogens out there in the skin, in your mouth, everywhere, that make sure your immune system doesn't just turn off because you wore a mask. Right. That is, in the words of my father, poppycock. So one bright note during, I'm going back on that one, people. One bright note during COVID is speculation that certain influenza type B viruses may have been decreased. Now, the word in the script says snuffed out as we sheltered in place. I don't think influenza B has been snuffed out. I'm going to turn to my panel of experts here in just a minute. Although, according to NIH, the H3N2 clade and the the B Yamagata viral sequences haven't been uploaded. Those are both influenza A and B. So let's parse this out a little bit. Again, Hawk, I'm going to ask you to kick us off. Help us a little bit with the nomenclature. Then I'm going to talk to my panel and have them put on their turban or whatever it is that Johnny used to wear on the Tonight Show, and he made predictions about the future.
Yeah, right. Okay, so, the H3N2 is an influenza A. The other one that we saw up there was an influenza B. There was some research going out there looking at the amount of uploaded sequences. So the only way we know what viruses are circulating is because we upload sequences of those viruses that are isolated from patients and are able to tell. And what that showed was that since 2020, those viral sequences really haven't been uploaded. Now, we should say that there are other specific H3N2 viruses within that clade. We know that there was a low amount of circulation of that H3N2 this viral season so far for influenza, but the vast majority of those people that were infected with influenza were the H1N1 subtype. Had a little bit of H3N2, had very little overall influenza B circulating currently. But just as you said in one of those emails, and we're going to make a quasi-ID doc out of you, Steve, that we had circulating around, and we had heard before earlier on the show too, we are always waiting for that second wave to come through with influenza, particularly the influenza B wave, which typically comes after that early influenza A wave. And we've seen a lot of the influenza A already. We know that the overall number of cases are going down. But I think this also lends to the amount of sequencing done and the amount of surveillance done, which overall we need to just increase around the world. Not only for influenza, but also COVID and other diseases as well. I think that just goes to infrastructure and the ability to do surveillance to really keep everybody up to date on what is truly going on in as much real time as possible.
All right, Dr. Lisa Hayes, I think I made a mistake and tried to, I apologize for not turning to you earlier, but Advent showing me, first of all, your numbers, and then second of all, your prediction is influenza B gone forever.
So first, my numbers, very similar to what everyone else in the panel is seeing. At Shawnee Mission, we had 21 COVID yesterday and 2 influenzas. We only had 1 COVID in the intensive care unit as of this morning, and that person was not on a ventilator. And then for our South Overland Park Hospital, we had 2 influenzas and 2 COVIDs yesterday. Our ongoing issue remains nursing staffing for our bed availability. The high amount of patients holding in the EDs throughout both Shawnee Mission as well as our satellite campuses, our freestanding EDs, and our sister hospital in Ottawa. It's not unusual that people are waiting multiple hours to be transferred to Shawnee Mission if they need to be transferred, having to prioritize taking patients out of the PACU after surgery and holding ER patients to be able to place those patients. Yesterday we had 7 employees out, and that actually is down and probably will go right back up today. I think that's a reporting issue after the holidays. As far as our total numbers, we're at about a fourth of where we were in our peak last year with Omicron, about the same time. But this is definitely the highest number of COVID patients we've had in the hospital since March, when we hit 0 at one point. So just kind of trending up over the last few weeks. We have not had RSV for a while, but we do not have a pediatric inpatient population. So as far as influenza B, I'm going to consult my ID colleagues. But I mean, like everyone else has said, the things that we know that work to reduce our risk of respiratory infections, such as masking, staying home, washing our hands, covering our cough, et cetera, that continues to work, whatever viral illness we're speaking of. And we will continue to recommend healthy public health measures in that measure.
That does make a difference. All right, Scrimshire, is influenza B gone forever?
No.
Good call.
I knew you were going to say
No.
that.
Good call.
No. I mean, I think that, I don't know that there's a good answer to the question of what's going on. I think that's multifactorial. Maybe it's outcompeted, maybe it's just too early. I'm not sure, because there is viral competition within a host. So if I get to somebody and infect them before you do, I win, type thing. But no, there's other populations that we're not monitoring, and B is ID for dummies. I think of B as year-round, A during the winter.
There you go. All right, so let's talk a little bit about the average life expectancy in the United States. It dropped to 76.4 years in 2021 versus 77 years in 2020. That's a little bit of a drop. And you say, oh, that's not too much. But actually, for a country where we've been trending up in life expectancy, we've been seeing drops the last few years. The average life expectancy is the lowest since it's been in 1996. The opioid crisis is also credited with the drop. But the two are also linked a little bit, according to the CDC, that is COVID, the opioid crisis, and others. In a report by the National Institute on Drug Abuse, smoking and substance use disorders are on a list of underlying medical conditions associated with a higher risk for severe COVID-19 illness. That includes opioid use. Let's talk about some of the reasons why smoking and substance abuse might be making a patient more susceptible to COVID, and in general, thoughts about why things are worse out there. Why is our life expectancy declining? I'm actually going to turn to Dr. Richard Watson first with motion. Dr. Watson, I know this is something you spend time thinking and having to look at. Talk to us a little bit about what are all the impacts on our life expectancy?
Well, thanks. I think the suicide and certainly the opioid crisis was there before COVID was there, and we saw that changing life expectancy, particularly in the upper 20-year-olds. From the standpoint of just having a population that's less healthy than we have been in the past, less activity, poor diet, all the things that tend to go with affluence in some ways. Again, kind of a resurgence in smoking and alcohol use. We're really seeing a population that's not resilient against disease. And certainly the COVID was an exclamation point on the end of that. But from the cheap seats, I will just say that until we really take health seriously in this country, we're going to have some real problems with ongoing chronic disease, and it's just it's not a rosy outlook for that set of population factors that continue to plague us.
I'm reminded that life is really a game of inches. Meaning the difference sometimes between life and death, you're in an automobile accident, was it just a little bit slower and so you didn't have as much contusion, or just the little near misses we have, the illnesses we have, and when we're less resilient, when we aren't active as much as we were, when we're not eating quite as well, when we're drinking a little more, those inches become miles, they make a big difference. Dr. Dishman, your thoughts from Stormont?
Sorry, getting myself unmuted here. I think we're seeing the landscape across America change. I think that we're having to focus very appropriately on things that we did not necessarily focus on in the past. I think about diversity and what we know from research that addressing diversity in all the communities and all the populations that we serve, and ensuring that we're meeting the needs of every member of our community, and ensuring that we're providing providers who have experiences that are similar to the communities that we serve and have an understanding of all those communities is critically important. Whether we're talking about an underserved community, whether we're talking about an impoverished community, whether we're talking about people who serve in the military, whatever dimension of our community we're talking about, ensuring that we're addressing the needs of every member of our society is going to be critically important going forward if we're going to tackle not only the chronicity of the COVID virus, but to address the needs of all medical care in our country. And so I really see that as an increasing concern, and the challenge that faces everyone on this panel today and faces our country is meeting the increasingly diverse needs of our country and meeting people where they are.
Yeah, I think that's really true, and I think that every time if we're not as well staffed, it takes longer to get somebody in for a time-critical diagnosis. We don't pay attention to those important variables of population health. We start to ignore segments of the population. We get angry with each other. All those things together means we're not going to be as healthy, right? We can't have open, honest conversations because we're too afraid of each other. Then we're not going to do very well. We're not going to prosper medically any better than we can anywhere else. So media and scientists have been routinely talking now and asking about brain fog and neurologic complications that happen following a respiratory virus. Recently completed autopsy research from 44 COVID-19 patients who died within the first year of the pandemic shows that the virus can spread throughout the body, including the brain, and remain in the tissues for months. Samples were taken from different parts of the brain and have been thoroughly studied, but we still don't know how the virus is affecting the brain. The research from the NIH was published in Nature recently. My question to colleagues: do your COVID patients continue to suffer long COVID neurological symptoms 3 years later, 2 years later, etc.? Are you seeing some longer-term complications of this? So first I want to turn to Dr. Edward Kammerer, Chief Medical Officer at Mosaic and St. Joe. Dr. Kammerer, what are you seeing from the long COVID aspect of this?
Well, definitely. I remember when long COVID was first proposed, everybody kind of thought that might be rubbish, but in reality, it certainly does seem to exist. And I will go to Dr. Scrimshire and Dr. Hawkins. And, if I'm correct, having anything in your brain besides your brain, blood, and oxygen is kind of bad. That's just sort of the internal medicine 101, right? I mean, so having this virus up inside your brain, and one of the things they taught us, right, is the first thing we noticed about COVID was it stole your olfaction, right? Well, that's a direct conduit to your brain. That means it's in your brain. It's a cranial nerve that's attached to your brain. When your nose went out, you had it in your brain. And again, I don't think that's a good thing for us long term to have anything else in our brain besides that. So I definitely am seeing some of that aspect, and I think it's. I hedge my bets a little bit. I always tell my neurological patients, strokes, etc., you'll generally improve with neurological issues for a year, and whatever you're left with at a year is pretty much what you're left with. If your big toenail itches a year after your open heart bypass, it's going to continue to itch. That's just sort of the way our body works. So I'm a little worried that I don't, some of these folks, they do get better. It takes months. But at a year, I'm, based on other diseases, I'm a little concerned that they will not continue to improve beyond that unless we can find something to assist in that. So I've seen plenty of what I call long COVID, and not horrible, but certainly does impact their life.
I think the blood-brain barrier is there for a reason. And when the barrier gets breached, things are bad, Hawk.
Yeah.
It's long COVID. What are you seeing?
Yeah, I mean, long COVID affects everything. You know, we're still looking at the mechanisms. We know that there's a large NIH funding to go ahead and look at the mechanisms for that, not only the brain, but also other organs such as the heart and the lungs especially. Still don't know exactly why. There are several theories put out there. You know, was it the maybe some continued antigen, or is it some inflammation that continues to happen, especially in the brain? But we also know that does happen with a lot of other infections as well, especially severe illness. But I think and hope and believe that looking at the mechanisms and trying to investigate the mechanisms of what's causing it for COVID-19 will also help in our knowledge for other entities that continue to cause these long-term effects as well.
Dr. Steele, we've talked a little bit today already about some of the income or some of the disparities between different groups, and one of my concerns would be that long COVID could disproportionately affect people from socioeconomic groups that have less access to care. Part of the mission, and part of the best mission of University of Health, is the way you reach across demographics. Talk to us a little bit about what you're seeing.
Yeah, I mean, I don't have any stats on whether or not certain populations are disproportionately impacted with long COVID, but certainly we have seen the impact of long COVID and some of the mental status changes that people come in with. We see, I mean, a lot of patients who come in or elderly can come in with an acute mental status change. And we've seen, even within our practitioners or employees, some people who have been very significantly impacted by this and sort of persistent brain fog, and have basically been knocked out of working for over a year. So for those who are impacted, it's a very significant thing.
I think it is a really significant thing. I'm with you, and I'm afraid that and you know, what we know is when you, especially if you're living paycheck to paycheck and then you can't work, you don't have time off, there's no PTO, that just affects your health that much more. It increases stress, and it increases, you know, what risks you may be taking, and some of the things that we talked about a little bit ago with the depression and anxiety. So, well, new cardiovascular research published in Nature shows a serious heart problem is 5 times more likely after being infected with COVID than after getting the COVID vaccination. Postural orthostatic tachycardia syndrome, known as POTS, and that's when you stand up, your blood pressure drops, your heart rate may go up, but you get really lightheaded. It is characterized by sudden bouts of rapid heartbeat, palpitations, lightheadedness, headaches, nausea, general weakness that can last for more than 3 months. Reports of POTS after receiving the COVID vaccine scared some folks from getting vaccinated. Most of that, though, is not true. The research shows people should be more afraid of COVID. I keep turning to my ID colleagues here, but first I want to turn to Dr. Hayes. What do you think about what's going on, and what are you guys seeing with this?
You know, I have not heard any specific instances of POTS after COVID or after the vaccine, but it just shows that ongoing research is necessary to really understand the long-term effects of this virus, particularly. But as you said, you know, we need to be most concerned about the respiratory acute effects of an infection. Those are much more concerning and much worse of an outcome than any side effects that I have seen from the vaccine, or any vaccine side effects that have been reported. So again, just to emphasize, vaccination over, you know, being infected.
Infection, yeah. And it's certainly, you may get infected even if you have vaccination, Dr. Scrimshire, but clearly the course of the disease is much better. You know, I had my bivalent vaccine, and then about a month or 6 weeks after that, I got COVID, and I basically had a mild cold, a little tired. Man, got through that without a problem. But Dr. Scrimshire, talk to us a little bit about this POTS thing and about ongoing fights around vaccination.
Yeah, I mean, you hit on two. I say all the time that medicine is humbling, and you know, long COVID and the neurologic side effects and POTS are two of the things that I feel, you know, kind of utterly helpless. I can't tell you when it's gonna get better. I can't tell you exactly why it happened. I think it's from COVID, but overall, vaccination is shown to not only have lower side effect profiles associated versus active disease, but long-term side effects have been proven to be less common after vaccination. So it's like one more, the scales are completely this way, but we just keep adding weights to the one that says you should get vaccinated. Unfortunately, I think at this point, a lot of people have made up their minds. It's very disheartening that the uptake of the bivalent booster has been so low. But I'm going to keep on keeping on. I'm going to recommend it to my patients. I'm going to talk openly about it and do my thing, and hopefully educated people are more likely to get vaccinated, and that's it.
Yeah, I think that's exactly right. All right, let's move on to the next question here. The final bit of research we wanted to share comes from a survey of doctors published in Stat News. They asked doctors what surprised them most about this pandemic. Many doctors and research agreed with Dr. Anthony Fauci, who listed his #1 surprise about COVID as being the continual evolution of the new variants, leading to an unprecedented persistence of the pandemic phase over 3 years. I'm going to ask each of you on this panel, what's been your biggest surprise about the pandemic? Dr. Dishman.
Well, I think Dr. Fauci said it. Again, I'm going to go back to the chronicity of this disease and the persistence. And I think, put very simply, it's the ability of this virus to adapt and to re-emphasize its changes that it's created, not only on our individual health, but on our healthcare system, and how we've been forced to continue to evolve. And that's going to continue. That challenge is going to continue into the future, and it will persist. And we have to remain flexible, adaptable, collegial, and continue to work together to ensure the health of all Kansans in our nation. And that challenge is not going away.
Yeah, I think that's exactly right. Dr. Hayes.
Yeah, I think the thing most surprising to me during this pandemic has been the lack of trust in our scientific experts. We trust experts in every other medical disease, whether it's diabetes, cardiology, primary care, pediatrics, OB. But for some reason, we have this scientific mistrust of our infectious disease experts and our vaccine experts. So that has been really shocking to me. I don't know what the next pandemic is going to be, but I feel that we may have been set back by our mistrust in society of our experts. And I have concerns how we'll respond to the next pandemic. So that's my greatest surprise, I would say.
Yeah, I agree. Dr. Steele.
Well, I think a couple of things. One is what others have already mentioned about how long this has been going on. I mean, we're sitting here nearly 3 years into this, and I don't think any of us ever dreamed that we would still be seeing the level of cases that we're seeing today. And then the other thing that, for me, I think is a bit surprising, we've already talked about it, is long COVID. I don't think any of us thought that people were going to continue to suffer with symptoms that go on for, as we've already heard, even years. And so I think those are the two things that come to mind. And what Dr. Hayes said, I think, is also absolutely true and a concern moving forward.
Yeah, Dr. Kammerer.
I'm going to fuse Dr. Steele and Dr. Hayes together. A couple things that I think are really interesting. One is the distrust. I'll give you a quick story of my best friend who owns a painting company, and he's an authority on paint. Now here's a guy who just absolutely will not get. I'm one of his best friends, if not his best friend, and it's fascinating to me that he has looked at the internet, he's read the internet, and he actually believes that is, Now I would never go when I paint my house. I go to him and I say, "Hey, what paint should I use?" Because he's an expert at paints, right? I mean, he owns a painting company. He knows all the different paints and how to use them. what's fascinating is the distrust of our science, because we really, that became on display here, and that's different than it would have been 30 years ago. None of us were prepared for that. And then I think then the other part was the business aspect of, and nobody likes that word, but the business aspect of medicine. We had this call, Dr. Steele, I really appreciate you and KU putting this on. We had this call, 3-4 months ago. And I went back to my leadership team and I said, the question out of the box from KU was, what are you going to do when we can't take your patients? Our whole system was built. We were told we were overbedded. We were built on this funneling and transfer of patients and everything. And all of a sudden, we're a 4-wheeled car that is operating on 3 wheels because of the pandemic. And yes, we can drive with 3 wheels. We're just not as stable because we don't, COVID not only, it's not that I can't transfer my COVID patients, it's that I can't transfer my intracranial bleeds or my other stuff because the tertiary quaternary centers don't have the capacity to take them because of COVID. So, it's less, COVID has impacted us tremendously. It disrupted our whole model, our whole system. That was the biggest surprise to me, was how fragile our system was business-wise.
Yeah, I think that's very true. I appreciate you bringing that up. Dr. Watson.
Maybe mine's a little more tragic. I just felt like, a lot of major events pull us together as a country. I felt there was a lot of divisive voices out there that really tore at the very fabric of who we are as people. And a lot of times we were pitted one against the other, a lot of times for what seemed to be political gain by one side or another. And it tied up money. It changed, sort of who were the experts that were moved out every day to give the latest prediction that was soon to be wrong. I think it humbled us in a lot of ways, and I like that word, Dr. Scrimsher. I think that's a story of the present. We need to be really humble as we walk through these sorts of things, and certainly among our people that we understand there's a lot we don't know, and certainly tearing each other down is the worst of us, and we need to be really protective of taking care of each other, taking care of ourselves as a country. And that very surprised me. Even in the environment we were in as we started the pandemic, it still seemed very tragic on every front for us as a country.
Dr. Scrimsher.
I will have to disagree with Dr. Fauci. I burst a lot of bubbles initially when I was like, oh no, this is not a year. We're talking years, if not 5 to 10 years. The surprising thing was that we had an effective vaccine so early, and yet we are still here. So that's what's surprising about this. The virus is going to do what it's going to do. It's doing what it was built to do, and that's not going to change. It's how we respond to it, and we did, kinda. The science was there, the buy-in was not. And I think the surprising thing to me was maybe not I don't want to say collapse of healthcare, but driving smaller hospitals out, lack of support, and the burnout and understaffing that we're seeing right now without the support of state, federal governments to help us. We are at a critical moment in healthcare, and without the support of everybody, ground up, environmental services to physicians, we are not going to make it out of the next couple of years, at least not unscathed or with many more hospitals, especially in rural areas, closing.
Dr. Stites,
please add to that.
I want to echo in on that, Dr. Scrimsher. I think that's, your point is really well placed. I think that was, it is a fascinating, I did a timeline on COVID. 11 days after Wuhan reported a atypical pneumonia, we had a sequence. 11 days. The response to this scientifically was remarkable. The response as a community has not been remarkable, right? I would agree. I mean, we partially responded. It's really fascinating. 11 days it took us from Wuhan saying they had an atypical pneumonia till we have the sequence, we know what it is. Now we just have to get a vaccine, and but yet the uptake was so poor.
Yeah, it is striking how fast the science moved. Jess, let me just see. Any questions today? Because I know we're running out of time. I just want to see if there's anything we should address.
Don't think so, but we have some community questions, and Donna is just giving a shout out to St. Joe. Just happy to have them represented today, and just appreciate everyone's fantastic information today. Anne has a question, and she says she's been hearing some chatter on Facebook that Damar Hamlin, the Bills player who collapsed on the floor or on the field on Monday Night Football, had recently been vaccinated. She doesn't believe that was a factor, but what are your thoughts about that swirling around there?
Yeah, we don't know enough about what's going on with this young man, and it's a tragic story. The worst thing we can do is start trying to spin this story into some political news story we want to believe off of what's on the internet. I think with the people who know the most are the people at the University of Cincinnati Medical Center. It's an outstanding hospital, it's an outstanding academic medical center, and I think we'll have to wait until we hear the whole story from the family and from the people who are directly involved in this young man's care. Our hearts go out to him. I'm a football fan. Anybody who's watched this program knows how much. But when you see something like that, it just shakes you to your core, and it's not supposed to happen. But tragedies do happen, and they happen to young people, and they happen to old people. They happen to football players. They happen to young children walking across the street. Tragedy is a part of our life, and what it's really about how we cope with it. Making up news or feeding rumors, that's not the way to cope.
Angela wants to know if you could discuss the deaths of younger men and the vaccine. Seems like that's all I keep hearing about lately. Thoughts on that?
Well, I don't know where they're hearing about it, Hawkeye. You're not listening to the right news stations. You're not listening to the real medical news.
Yeah, I'm not sure exactly. It would certainly need more details on that question. I'm not sure about death and the vaccine. Again, what we have heard constantly, and Dr. Scrimshire talked about this, the overwhelming vast majority of the data continues to support the efficacy and the safety of the vaccine. And getting the vaccine reduces your risk of potential complications, hospitalizations, and death by far more than getting the infection itself. And that includes whether that's long COVID, whether that's POTS, whether that's actual myocarditis. And to tell you the truth, the worst cases I've seen of myocarditis, viral myocarditis, have really happened with influenza and other respiratory viruses, unfortunately. But the overwhelming majority of the data continue to support that the vaccine is safe, efficacious, and overall lowers your chance of those complications, whether that is myocarditis, whether that's long COVID, hospitalization, and of course death.
And and we just know that even though there were some initial case reports of having some myocardial inflammation or heart tissue inflammation from after the COVID vaccination, it's mild, it's short-lived, and it doesn't kill you. No. Unlike what happens when you have COVID itself. Jess.
Jean wants to know, can the COVID vaccine trigger allergic reactions like eczema?
Jen, I think any vaccination can trigger some sort of allergic reaction. I don't think that eczema is directly responsible, or is the vaccination is truly responsible for eczematous outbreaks, though. Scripture, that's my way of making a statement. You're supposed to agree with me, just in case. Just want to make sure you know.
Sorry, yes, I absolutely agree, Dr. Stites.
Vince wants to know if anyone on the panel or here at the health system, if we know the numbers of patients who are inpatient with the bivalent shot, people who are fully boosted.
Yeah, we know that the folks who are vaccinated and have had the bivalent, fully vaccinated and had bivalent, are vanishingly small in our hospital, Hawk.
Yeah, that's exactly true. And the ones that are, these are patients who have, again, trust in the medical system, trust in their care providers. These are people who have significant comorbidities, such as they're on chemotherapy because they have leukemia or other cancers. They've had a bone marrow transplant, solid organ transplant, have other significant immunosuppressive conditions as well. But the vast majority of those people that are in the hospital and have had their updated booster is exceedingly small, and of those, again, have significant comorbid conditions which put them at risk of complications as well.
And I'm just going to try panel. Anybody think differently? Nope.
I echo the same exact statements. Less than 5% of our people that are hospitalized have had the bivalent, and of those 5% that have been, it's all been, acute chemotherapy, AML, acute leukemias, those type of things that are severely immunosuppressive.
Yeah, those are just the diseases that are just bad for you.
Yeah.
Jess?
Yes, Amy has the last question today. I have MS and I'm on immunosuppressive medication. I continue to mask with those heavy-duty masks. I've been masking from the very beginning, back in 2017, actually, when she was diagnosed. Will masking continue to be the normal for her, do you think, from now on?
I think that's a hard question for us to answer because we don't know all your medical history and the medications that you're on, Hawkeye. So it's a little bit hard to say. We tell our transplant patients, I know, to stay masked when they go out in public, and especially when we know there's this big outbreak because they're immunosuppressed. But I don't know what all the medications this young patient's on with MS. Yeah,
I would agree. I think it's those places they go to as well, and it sounds like this has been happening since before the pandemic. Likely then, if nothing really has changed, it will happen after these new surges go on as well. But it's always taking into account your risk, but also those environments that you're in. I mean, obviously, if you're outdoors, it's going to be much safer than a small area that is not ventilated well. So there are so many other factors as well that will contribute to that answer.
Hawkeye, I didn't ask you what your most surprising thing about the pandemic was.
I was hoping you'd skip me. I think there's so many things, but I think really the thing that stands out was definitely the point of the active attack on science and medical professionals who are using objective data and really trying to follow the science to help people get through this. It has become more divisive. It seems like it's certainly more of a political ploy to attract constituents and voters. But this is something we have seen throughout history with various organizations in various countries doing that to gain prominence or power, trying to politicize something that really is objective and doesn't have to be politicized, really for the main goal of trying to protect you and your loved ones.
I want to thank all the members of our panel today. Dr. Mark Steele, Executive Chief Clinical Officer, University Health at Truman, Dr. Jeffrey Scrimshire, Infectious Disease Physician at LMH and Chief Public Health Officer for Douglas County, Dr. Edward Kammerer, Chief Medical Officer at Mosaic and St. Joe, Dr. Heather Harris, the Medical Director for Hayes Med, Dr. Lisa Hayes, Chief Medical Officer at Advent Health Shawnee Mission, Dr. Kevin Dishman, Chief Medical Officer at Stormont Vale Health, Dr. Richard Watson, the co-founder of Motion, and our very own Dr. Dana Hawkinson, Infectious Disease Physician and Medical Director of Infection Prevention Control here at KU. I said that very rapidly. Watch out, Lin-Manuel Miranda, here I come. So here's my biggest concern, here's my biggest surprise about the pandemic. I'm surprised by paranoia. And I think what I mean by that is our shift from listening to each other into taking a simple act of human kindness, wearing a mask, which our surgical teams do every day in the operating room, into an act of political division. Our reliance on the internet as a source of truth, as opposed to science, and the folks that you know spend their lives devoted to the care of patients every single moment of every single day. Paranoia is a funny emotion. It's a funny way of living. Usually great crises bring people together. For some reason, we've allowed COVID to split us apart, which just made it harder to take care of every patient with a heart attack, a stroke, with cancer, or anything else. I think we have to make sure in the next 10 years, our next big goal has to be to pull ourselves back together. But to do that, we have to believe in reliable, honest sources of information from people who really work in a field and do things every day to try and make it better. Now, that doesn't come from internet trolls. It comes from good, honest conversations between those who are experts in a field, be they a painter, I love that story, or they be a physician or a scientist. If we can do that, we can heal a lot of wounds, and not just COVID. Jess, we're back tomorrow.
Yeah, well, we're back live on Friday. So we'll be
Sorry, I
back
meant
Friday
to
with
put-
our next. Well, we'll be back with our first live edition of the Morning Medical Update of 2023. So that's really exciting. And then tomorrow, we hope everyone will enjoy an encore presentation of one of our favorite episodes. So get out there, make it a great day. We'll see you back here live on Friday. A young pregnant mom drops to the floor. She knows something is wrong.
I couldn't move the left side of my face at all.
Leslie Pratt was having a stroke. I'm Jessica Lovell. Coming up on the next Morning Medical Update, meet Leslie and the extensive team who worked minute to minute to keep her and her baby safe until time for delivery. You won't want to miss this story. Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.